Okay, greetings everyone. Larry Eichenfield here. First of all, we have, we're doing Zoom, so people in attendance feel free to put on your chat function. So if you have questions or comments as we go through, that's the way we can get your input. Thank you for joining us. I'm sure we'll get more people assembling in the next few minutes, but why don't I get us started tonight. So this is our second webinar in our PeDRA virtual education series on emerging therapies for moderate severe atopic dermatitis in children. And last week we had our first session where we discussed some of the data sets on new systemic therapies and and then heard a perspective on allergy perspective on systemic medicines, and started our discussions on sort of how management of atopic dermatitis is changing. And tonight's seminar is called Algorithms of the Future, and we're going to discuss we're going to start off by discussing new topicals that are in development and or recently approved, and then go on from there to have a discussion of how everything's going to fit in, both with systemic medicine, and then we have time set aside to discuss some hot issues that we'll be facing in pediatric dermatology research. So without further ado, Michael, yeah, so I'm Larry Eichenfield down at Rady Children's Hospital in UCSD. Joining us tonight, we'll start with the bottom right because Winnis will be leading off the discussion. Winnis is a professor of dermatology and pediatrics, also the fellowship director at Rady Children's Hospital, UCSD San Diego. And Dawn Davis will also be a featured speaker. She's professor of dermatology and pediatrics and division chair, and director of pediatric derm at Mayo Clinic Rochester, also one of the two people, along with Rob Sidbury, who are chairing the new guidelines group for the AAD on atopic dermatitis. And Mega Tollefson, associate professor of dermatology and pediatrics and consultant in dermatology and pediatric adolescent medicine, also at Mayo Clinic. And then Bob Gang will be joining us. He's assistant professor of medicine and pediatrics and allergist at Rady Children's Hospital. He's co-director of our multidisciplinary Atopic Derm Center, as well as the Allergy Asthma Foundation sponsored severe asthma program, and president of the San Diego Allergy Society as well. So that's our crew for today. Disclosures, you can see a list. Dawn has none. I have a significant number that I'm consultant investigator on. Bob Gang served as a speaker consultant for several companies. Mega has been investigator for Pfizer, and Winnis has been an investigator for multiple companies. This series is actually, we received an independent medical education program through a competitive application process. So we thank Pfizer for the funding to PeDRA, but there's been no influence of content at all. We did what we wanted to do to discuss atopic dermatitis. So we're solely responsible for the program content and for choosing this crew as faculty. So thank you. It looks like Mega's full professor, so yay! Congratulations. That's it.
Thank you everyone.
So we're gonna, I've done the introduction. We're gonna go to, Winnis will discuss new topicals for moderate severe disease. Then we'll do new and traditional systemics. Where do they fit? We're gonna have general discussion on then figuring out what's the right therapy for the right patient and hot research issues. Without further ado, we'll turn it over to Winnis.
All right, next slide, please. Okay. So a mom brings in her 4-month-old for atopic derm, has applied 2.5% hydrocortisone with some improvement, but as soon as she stops it for a couple days, and of course the lesions start to come back, and mom is worried to keep using it. So she asked you, are there other non-steroidal options that are available? I'm sure we all face this in our clinic pretty much daily. And the good thing is that we do now finally have one non-steroidal topical that's been approved for use in our infants. Next slide. And that's topical crisaborole. So the approval was based on a phase 4 study, which was open label. So infants from 3 to 23 months of age were treated twice a day for 28 days. And the main study, it was infants who had mild to moderate disease with at least 5% of their skin affected, excluding the scalp, mostly for the aesthetics. But there was a subset also included that had moderate disease over at least 35% of their skin, excluding the scalp in areas where they were worried that the child might put the ointment and get it into the mouth, to do pharmacokinetic analyses with that. So overall, they enrolled 137 subjects. On average, the age was about 13 months, and they had had the disease for about 10 months. So on average, about 3 months of age of onset. 40% of the kids were mild, about 60% were moderate, and then one severe patient got snuck in. About half of the patients had used topical steroids previously, and except for a very small handful, none of them had used topical calcineurin inhibitors, since it is more difficult given off-label use. Next slide. So overall, in terms of the study, their primary endpoint was actually safety, to look to make sure that there were no major adverse events. And in general, all treatment emergent adverse events, so any type of event, treatment related or not, were all mild to moderate. There were no major severe events. In terms of actual treatment related adverse events, the biggest one seen, which is not that unexpected, was application site pain, which is about 3.5%, or application site discomfort, about 3%. Some individuals had some more redness, and then about 6% had worsening or new atopic dermatitis lesions during the treatment period. Now, of note, a small percentage also had worsening after the treatment period as well, which could be a reflection of actual response with it. Sorry, if we can go back a slide for 1 second. Okay. But really only 3 subjects, so 2%, actually stopped treatment as a result directly from either having application site pain or one had infected dermatitis. So as a whole, most stayed in the study. And in terms of looking at safety, systemic exposure to crisaborole was comparable to what we had seen in older individuals. So even though the kids are younger and you're using it over a area of age, they didn't have more absorption with it. And they also measured propylene glycol levels, because propylene glycol is one of the constituents, and very, very high levels has been associated with neurologic or cardiovascular findings. So they did check this in case, and none of the subjects had any incidents related to this. Next slide. In terms of actual efficacy, so we look for the common criterion for success, which is that the investigator severity global score goes down to clear or almost clear, and it improves at least 2 grades. By the time the 29-day period was finished, about 30% of patients reached that. If we look at those who just achieved clear or almost clear, with at least 1 grade improvement, which means some could started off at mild and gotten to like almost clear, for example, then close to 50% of the subjects did achieve that. And overall, if you look at the EASI score, it decreased by about 55 to almost 60% from baseline. Next slide. And then POEM, in terms of looking at patient-reported outcomes, all of the parameters did show some improvement. The ones that parents answered that improved the most was itch, flaking, and dry and rough skin. Next slide. So overall, the benefits of topical crisaborole ointment is the way it works is it's a phosphodiesterase 4 inhibitor, so it's decreases inflammation, but it's not actually considered immunosuppressive, so that's one benefit. There's been no associated skin atrophy as well, and like I said, it does provide a non-steroidal treatment for our young patients. But as seen in some of our older patients, there is some notable application site pain and discomfort. So I do think it's appropriate at times, depending how red it is, to use topical steroids first to decrease the inflammation, and then consider switching to this. Okay, next slide. But what about if the atopic dermatitis is more significant? So more moderate to severe disease or more long-standing disease, which has been more refractory to other treatments. Next slide. I think this is where we have some of our other new topicals will come in well, which we've been waiting for, and that includes topical Janus kinase JAK inhibitors. So we heard, as Larry had mentioned, a bit about oral JAK inhibitors last week. There are some topical JAK inhibitors that have made their ways along the clinical trials. And just as a recap, these are important molecules. These are transmembrane molecules that are involved in signal transduction, including transmitting the signal from IL-4, IL-13, which are major cytokines involved in atopic dermatitis, IL-31, which is involved in the itch of AD, and then leading to increased gene transcription in your inflammatory cells, leading to more pro-inflammatory cytokines. So right now, there are really two, next slide, there are two topical JAK inhibitors that have gone to phase 2 and 3 clinical trials. And one is Ruxolitinib, which is a JAK1 and 2 inhibitor. And then the other is Delgocitinib, which is actually a pan-JAK inhibitor that inhibits all 4 of the transmembrane receptors. Next slide. So topical ruxolitinib cream has been studied in 2 phase 3 randomized double-blind vehicle-controlled trials. And these involved individuals 12 years and above, so adolescents as well as adults. And this was still mild to moderate AD for at least 2 years and anywhere from 3 to 20% body surface area. If we look at the breakdown, about 20% were adolescents, and then about a quarter had mild disease, 3/4 had moderate disease. And the way the trials were both designed the same. It was 2 to 2 to 1, meaning 40% of patients would get 0.75% ruxolitinib twice a day. Another 40% got 1.5% ruxolitinib twice a day. And then the last bit in the vehicle got just the vehicle alone. And that was for the first 8 weeks. After the 8 weeks was done, there is then a long-term open treatment study where those who got vehicle would get randomized to either of the concentrations of ruxolitinib, and those who originally got active drug would continue on their treatment. Next slide. So I'm showing mainly the data from just one of the trials, just because both had pretty similar findings between them. And this is the 8-week data. We don't have the long-term data yet. So again, if you're looking at the percentage of patients who were considered responders. So again, they had their global scores go to clear or almost clear and at least a 2-grade improvement. By the end of the 8 weeks, the ruxolitinib treated kids were between 50 and 54% did achieve that, versus vehicle was 15%. If you want to try to make a comparison, looking at the crystal ball study, so if you remember what I had said earlier for the infants, that was pretty comparable at 4 weeks. However, I do believe, infants have less refractory disease, right? They haven't been treated much. If you looked at the later crystal ball studies in those, who were 2 years and above, including adolescents, the difference between active drug and vehicle was probably like between 8 and 15% difference in terms of the responders relative to the vehicle. Versus here, you're talking about 35 to 40% difference. So, I mean, they're not head-to-head studies, but just to try to put it a little bit into perspective. If we look at those who got at least a 75% improvement in their EASI scores, that reached about 55 to 60% of patients who got active drug versus 25% of those who got vehicle. So overall, you can see there is a difference in the decrease in EASI score. In addition, they also looked at itch. So for them, success in itch was a decrease in the 10-point numerical rating scale of at least 4 points or more. So those who got active drug, 40 to 52% of the subjects had achieved that much decrease in itch versus only 15 and 16% of those who were treated with vehicle. Next slide. The other thing to look at, so if you look at the graph on the left, is actually looked at the change in the patient-reported itch numerical rating score over time. And what you'll actually see is that they've started to reach statistical significance even within the first day of starting to use the topical ruxolitinib cream relative to the vehicle. So it seemed like the relief from itch was actually pretty quick early in the treatment course. And all their adverse events were also, again, mild or moderate in severity. And there weren't any adverse events that suggested that there was too much systemic exposure to the JAK inhibitors, which of course is important, as we talked about with the oral medicines last week. In terms of looking at some of the treatment-related adverse events, I think what's best, to kind of look at is application site burning. So if you look at vehicle, about 4% of patients reported burning, but it was less than 1% in those who had gotten active drug. Itch was also less at the site of application, 2.5% in vehicle, less than 1% in those who got Ruxolitinib as well. And the percentage of patients who discontinued drug was, again, half as many in those who got active drug as opposed to those who got vehicle. Next slide. So, overall, I think, Ruxolitinib is probably the farthest along, and we'll have to see where they're at in terms of approval. We'll see if Larry maybe has some information about it. But the long-term studies are continuing to ongoing, and they are doing, have completed, I think, the PK studies for the younger kids, and they're looking at hopefully a phase 3 study, for those less than age 12. The other topical JAK inhibitor that's also further along is topical Ruxolitinib, 0.5% ointment. So this is actually approved already in Japan, beginning at this year for adults with atopic dermatitis. And they in Japan had conducted studies, including 3 phase 3 studies. One was a 4-week study of treatment. Now here they were aiming for individuals with moderate to severe disease. And then at least 10% up to 30% body surface area involved. And then there was a 24-week open label extension as well, in which they did allow some topical steroids for rescue if needed. And then they also conducted a separate 52-week open label trial of over 500 patients to see, what was the effects of using this ointment. And you can look and see in the graph in the bottom, so I showed this open label. So about 50% of patients reached at least a 50% improvement in their modified EASI score, which they decided to do a score that didn't include the face in that case. It was done separately. And then if you look at those who achieved at least 75%, it was close to 25% of subjects. And again, most of the adverse events were mild. They did see about 4.5% contact derm, a little bit of acne, as well as application site folliculitis. But there was infrequent application site irritation. It was less than 2%, and then no skin atrophy or telangiectasias as well. Next slide. So they have done one phase 2 randomized controlled trial for children 2 to 15 years of age with AD, and so this was a 4-week study. And so they got either 0.25% Ruxolitinib, 0.5% Ruxolitinib, or vehicle. And so if you look at the graph, so if you look at the top left, which is looking at, again, at least a 50% improvement in the modified EASI score, you can see there the 2 concentrations of Ruxolitinib did about the same. If you look at 75% improvement, then you're starting to see that the 0.5% ointment did a little bit better. If you look at those who actually achieve, IGA success, which again is getting to a score of 0 or 1 with at least 2 grades improvement, again, you're seeing the 0.5% doing a bit better than the 0.25%. So I think Leo Pharma is now working on this formulation. In fact, they're actually looking at a cream, I think, into the United States. So we'll have to look and see in terms of the studies, what will happen. But it looks like, based on these, hopefully this will move forward as well. Next slide. And this just showed some of the other responses. So if you look at pruritus, again, active treatment, you can see on the upper left did much better with the decrease in pruritus versus, pruritus fluxed a lot with vehicle. And then also in terms of the decrease in pruritus, you can see also was significantly significant with treatment compared to vehicle. And these were some of the photographs they included in the publication in terms of the actual changes seen within the skin. Next slide. So, I think those are exciting in terms of another class that is coming, hopefully soon. What else is in the pipeline? I think the other molecule that's of interest is tapinarof. So this is actually a small molecule that's actually produced by bacterial symbionts. So what it is, it's mainly a topical aryl hydrocarbon receptor agonist, and this is actually the pathway by which we think coal tar works to decrease inflammation. But in addition to seeming to inhibit some of the inflammatory pathways like interleukin-4 and STAT6, it also looks like this pathway also seems to enhance actually skin barrier function and epidermal differentiation with increased levels of filaggrin. So I think, we're interested in this molecule because it may be, both anti-inflammatory as well as hopefully helping with actual skin barrier as well. Next slide. So there has been completed a phase 2b double-blind study of both adults and adolescents 12 years and above. And again, this one was moderate to severe atopic dermatitis, from 5 to 35% of their skin affected. And they were treated for 12 weeks and then followed for 4 weeks. Overall, the vast majority of the enrolled subjects had moderate disease, those 90% of them. So there isn't as much, data from the severe patients. But still, it's a good group to start with, and close to 40% of the subjects were adolescents. So if you look at the graph there on the right, the lower two is vehicle. So they had tested vehicle once versus twice daily, and then 0.5% once versus applied twice daily, and then 1% once versus twice daily. And you can see by the end of the 12 weeks of treatment that mainly the 1%, whether it's once or twice daily, had statistical significance in terms of reaching clear or almost clear, and at least a 2-grade improvement with it. And then overall, about 30% of those who got active drug had improvement of at least 3 points in their pruritus itch scores, as opposed to only 5 and 15% seen with vehicle. So about double the number of patients who got vehicle experienced improvement in pruritus. Next slide. So in terms of adverse events, here they did see a little bit of folliculitis, about 5 to 7% at the sites of treatment, versus vehicle didn't have it. There was one subject that got HSV infection. This was with the lower strength. But overall, subjects did improve, and there were fewer subjects who got active drug that stopped treatment as a result of worsening of their atopic derm. So 4% stopped it versus 7% in vehicle. And overall, there was very little application site irritation or burning, stinging reported by both the investigator on asking as well as self-reported by the subjects as well. And again, these are clinical pictures showing the results. Next slide. So I think in conclusions, I think, we're excited to see that there are, now more, especially anti-inflammatory and for more, moderate and potentially severe patients who have options that they can treat that are non-steroidals. And I think, it's alluded to, and we can discuss a bit, management algorithms will definitely need to be refined, but it looks like, it should be for the better, as we'll have more options, especially for those more severe. Thank you.
Thank you, Winnes. So I think we'll move on now for Dawn to discuss new and traditional systemics, and then we'll have more extended discussion about both talks.
Good evening, everyone. Today we'll just talk about, now that Winnes has reviewed topicals, we'll start back at the basics and work through where we're going now. Next, please. So it's sort of like eating your vegetables. When we see patients with simple to complex atopic dermatitis, we want them to still remember the basics of skincare and not become simply mentally a drug-dependent family, or if I just use this one medicine, it's going to make all my AD go away. We still want them to practice the basics. And in my mind, what that means is a sensitive skincare routine that involves bathing more rather than less, and definitely using an emollient afterward, because studies have shown that that helps with transepidermal water loss, and it also helps with regards to irritation of the skin. We, of course, need to address comorbidities, and our friend Bob Gang, who's the allergist on our panel, would hopefully support that as well. If somebody has other atopic disease, such as asthma, allergic rhinoconjunctivitis, eosinophilic esophagitis, or food allergies, etc., and isn't getting management of those diseases, their atopic dermatitis will not settle down nearly as easily, even if we're giving traditionally appropriate medications. And then, of course, we want everyone to avoid allergens. And there's kind of a different train of thought as to how to do this. You can either have them avoid the most common allergens for children, or you can do official or unofficial patch testing in kids. We'll get to that in a moment. First line therapy for all after sensitive skincare includes topical corticosteroids. And then, as Winnes reviewed with us, the topical calcineurin inhibitors, which are technically FDA approved for children 2 and up, although we do believe that they are likely safe for children under 2. And then the topical PDE4 inhibitors, which are FDA approved, as we just heard from Winnes, for children 3 months and older. Next. Additional tools that we have in our kit if sensitive skincare alone and some topicals is not assisting with clearance of disease or good control, include official or unofficial patch testing. It does help if you have a pediatric specific patch test series based on the literature that's available that shows that the contactants are not necessarily equal and the same between adults and children based on age distribution. And then, of course, the use test, which means that if you don't have patch testing available, or if there's a particular chemical or component or cosmeceutical that you have concern about, you can do what's nicknamed the cheap man's patch test and place a little bit of the product under occlusion for 3 consecutive nights and then watch to see if that develops any sort of local irritant reaction. And then we move on to the concept of phototherapy. There's official phototherapy, usually narrowband UVB, that can be done in the dermatologist's office, which of course is age and patient comfort dependent. We use phototherapy in our office commonly and can get down to about age 3 with our phototherapy nurses if the parents and patients are willing. But we can also use natural sunlight in moderation for patients who live in southern locales or during the summer in the northern areas. We can also say, you know, please get a little bit of sunlight every day, but make sure not to burn, just to get a mild tan. And whether some people consider phototherapy truly the second line therapy before you'd go to systemics, some insurance companies do require that. It tends to vary, at least in my patient panel, as to whose insurance requires a phototherapy trial before you go to systemics or not. But oftentimes you can do home phototherapy units for people who respond to office phototherapy. And then, of course, we know from the recent AD guidelines, and they will be updated soon in the next couple of years, that there are some patients who do appropriate first-line therapy and trial narrowband UVB in the office. And unfortunately, that makes their atopic dermatitis worse rather than better, but a substantial percentage of patients do find benefit from phototherapy. Next. So beyond the basics, I just think it's important to pause when we have discussions with parents about systemics, because I don't own a magic wand and I know my patients wish that I did, but there's so many psychosocial issues that go forth with taking care of a patient in a family unit that suffers from atopic disease. And we all know this because this is what we do daily in our practice, but it's important to remind them that this is more than a skin disease. It's a multi-system inflammatory disorder that really impacts the patient and their quality of life and the family unit by proxy. And I think it's really important to express this because parents and patients have a lot of worry, a lot of guilt, and they need validation and they need to know that you hear them and understand that. And of course, we're all very mindful to practice whole person care. I think it's important for patients to understand that the dermatologist is here more than just to treat the skin disease, but to address them as a patient and family unit. And we try it best based on patient age and intellectual and emotional ability and autonomy to put the patient at the center, and gradually the autonomy goes more towards the child as they grow, particularly towards adolescence, and less towards the parental unit. But as we know, at times that can be challenging, and there are, of course, unique circumstances. But we all know that we have patients that go through that, you know, early teen year and late adolescent rebellion where they don't necessarily want to take care of their skin, even though psychologically they're quite embarrassed and impacted by it. And then it's no surprise to any of us that, of course, caring for an atopic dermatitis patient takes a lot of time and effort on the patient and family, and is also very costly. There's multiple visits to the primary care providers, to dermatologists, to allergists. There's a lot of time and education that needs to go into treating atopic dermatitis because it is a chronic disease. So it's similar to having a patient with a seizure disorder or diabetes or asthma, where it needs several sessions and lots of back and forth between the care provider and the patient and their family unit, so that the family and the patient feel comfortable with their plan and knowing what is a flare and how do you dial up and dial down the treatment. And then of course there's all the logistics. You know, we can throw the kitchen sink at our patients and give all these regimens of what to do and how often to do them and what to avoid and don't do this and do that. And it can be quite time consuming and overwhelming because work, school, and just life gets in the way. And we also have to worry about logistics with regards to insurance coverage and prior authorization. And then of course other things such as feasibility and palatability, because a lot of times what we do doesn't feel good on the skin, or perhaps it stings and burns. Next. So with regards to that, we'll do systemic therapies. Next. So really there is a paradigm shift. We used to think that systemic therapies were second-line therapy only after sensitive skincare, and first-line therapies and perhaps even phototherapy have failed. And now we're realizing with the advent of these drugs that we're now able to do things quicker, faster, and sooner, and not necessarily only for moderate and severe disease, but rather for other patients with atopic dermatitis. And that's really what we're going to discuss today. So really we should have a new mantra that is earlier, faster, quicker, not necessarily only for generalized disease. And then we can also use these methods because they cross over on multiple atopic inflammatory cascades, about helping the patient who has comorbid disease, because perhaps they could have one drug that would really improve more than one atopic disease at the same time, avoiding polypharmacy and also simplifying the regimen, which helps with compliance, and also decreasing cost. And of course, anytime you start a systemic therapy, it's sort of like Accutane. The patients in my clinic who want Accutane are usually those who don't need it, and the patients who need Accutane are usually those who don't want it. And sometimes that can be said about atopic dermatitis, where some patients purely want me to put them on a systemic medicine, and then a lot of patients who need systemic medicine are fearful. So there's always overcoming the hump of patient and parental hesitation, and of course, arm wrestling insurance companies and prior authorization forms. Next. So traditional systemic therapies, which we will review, as you know, are traditionally immunosuppressive. They're usually thought to maintain chronic disease, and oftentimes you have a drug onset timeline, then you get a drug holiday, and then when you flare again, you go back onto the drug, and it's a cyclical process. There's questions with regards to when do you start treatment, and then of course, when do you stop treatment? A lot of patients end up stopping treatment due to side effects, or insurance expires with regards to, they only give a particular time window. And then of course the question of vaccines always come up when you give an immune suppressive drug. Do you give live vaccines? Do you not? Do you delay vaccines? If you know that you'll only be on the medicine for a brief window of time, perhaps you just simply delay them. And so that's always a question. And then of course we have to worry about the traditional things that we did with all the other medication coverages, which would include insurance. If there's any lab monitoring required, kids don't like to have their blood drawn, the logistics of who's going to follow all those labs, and getting them communicated to your office. And then of course, other relevant medical history, because some of the drugs that we use do have some contraindications to consider. Next. So the only FDA-approved systemic drug that is old, of course, is systemic steroids, which as we know as dermatologists and allergists, we suggest not to do, and it's a big red flag. And we all know patients that I say, kind of become addicted to steroids, and usually those are the patients who go through urgent care or emergency rooms with flares. They get a drug holiday, or perhaps they've had a bad asthma attack and get a drug holiday from systemic steroids. They feel temporary relief. They can't believe how good their skin looks and feels. They feel better, although they might be a little hungry and slightly irritable. But on a relative scale, they're doing much better. And then of course, once the systemic steroids wear off, they've dug themselves into a deeper hole than they started at. So systemic steroids, as you know, tend to be a no. The first line therapy that I use in my office with regards to what's old is methotrexate. I believe it's a good drug for pediatric patients with a low side effect profile, does require some med monitoring. It is quite slow in onset, typically about 3 months in time. A lot of patients can get quite nauseated and fatigued. You can try to oscillate between the oral form and the injection form to see if that helps one patient versus another. A lot of my patients who do the injections tend to take them over the weekend, so that way they can kind of have some downtime and have some rest. Also common in our practice, but less common for me personally, would be cyclosporin. I don't use it as often. I think of it as a rapid onset drug, usually working within 3 weeks versus 3 months. However, it's a drug that I think of as using shorter term, 4 to 6 months. And I think of it as like a light switch. It tends to give you a very nice skin holiday, so to speak, but I don't think of it as something that you use longer term. I think of methotrexate in that course. Then some things that I don't use today in my office, and I don't think others use commonly as well, would include mycophenolate. It is very well tolerated typically by patients, but we wonder if it truly works. And then azathioprine requires lab monitoring, and a lot of people get so much GI disturbance that they're not able to tolerate the drug. And even though it helps clear their skin, they're just so miserable in their gut that they stop the treatment. Next. So of course, as we reviewed in the last module, there are focused immune suppression, or rather immune modulators, available on the market, including biologics, which are monoclonal antibodies, and then JAK inhibitors, which are non-antibody medications that work by inhibiting the dimers, as Winnis explained, that then stop translation of interleukins and nuclear transcription. And those include dupilumab, currently approved for ages 6 and older, tralokinumab, currently no pediatric data on that, lebrikizumab, currently in phase 3 trials for children 12 and older, and then of course the pediatric favorite, nemolizumab, with trials in process. And then with regards to systemic JAK inhibitors, not to be confused with the topicals that Winnis just reviewed, include abrocitinib, which is in phase 3 trials for children 12 years and older, apapidizumab, I can never say that word, apodicitinib, phase 3 trials 12 and older, and then baricitinib, phase 3 trials, but no current studies on children. Next. So what do we think about when we talk about these new therapies, old versus new, and what to do for your patient? Next. It's about the right patient to the right provider at the right time with the right drug. So there's a lot of art to this, and the science is progressing, and we're probably going to shift what we're talking about now. Will evolve over time over the next few years with more studies. But at this time, we need to think about such things as, what do we do for the localized disease patient? What do we do for patients with multiple atopic comorbidities? What about the duration of treatment? How long do we use these new drugs? And then safety profiles. We all know of drugs that have come out and are deemed to be safe, but then once thousands of people use them more readily, there are less common side effects, and sometimes they can be quite adverse, that come out and become evident with time. And then of course, speed. Some drugs will work faster than others, and it's very hard to be patient when you're inflamed and uncomfortable. So next. So we always talk about the atopic march. Bob reviewed very nicely in module 1, as we are all familiar that usually when a patient has multiple atopic comorbidities, the skin disease comes first, followed by the food allergy, and then environmental allergies. So when we think about drugs and the therapies to approach the patient, do we think about it as a therapeutic march, where we would start with sensitive skincare and the basics always, and do we feel obliged perhaps to go through first-line therapies with topicals plus minus phototherapy, and do we feel obliged to try something old such as methotrexate or cyclosporin before we trial something new? If insurance and prior auth weren't in the way, would we go straight to something new? And then if we think about the new drugs, do we start off with the inflammatory anti-IL-4 and 13 inhibitors, or for patients that have worse itch, do we start with the IL-31 inhibitors? These are questions that we still have today. Next. So here we're going to open up to our panel discussion and kind of chew on the art versus science of these drugs and what we know now. Firstly, the topics of localized disease. Are there certain drugs or mechanisms that you would use first? For the isolated AD patient, most commonly the face, the genitalia, or perhaps localized to the hands and feet.
So yeah, let's have Mega and Winnis pop in as well, and let's weigh in. So I think, Bob, do you want to make some comments about the quick discussion that we had on systemics now, and how you approach a severe patient when you see them first referred to allergy? How much do you oblige to go through steps? Do you consider the older systemics, or how do you handle that?
Well, I think that I am very excited about all the different targeted precision medicine that have been introduced in among all the panelists here in the various discussions between the biologics to the systemic JAKs and the topical JAKs. I think that the future of atopic dermatitis is going to be in precision medicine, targeted therapies. As an immunologist, I'm very weary about the use of some of the traditional systemic therapies, the more non-specific ones, primarily because we're very aware of secondary immune deficiency. In fact, I can't really talk out of one side of my mouth by it, because I also run a secondary immune deficiency surveillance program for a lot of our solid organ transplants and hematology, oncology, and rheumatology colleagues who send patients to me when they put patients on methotrexate and cyclosporin and end up leading to secondary immune deficiency. And I'm managing those. And on the other hand, say, hey, I'm going to start handing that out, these things for other conditions that I treat. So I'm very excited about the fact that we do have dupilumab right now, and I'm also even more excited about some of the oral systemics that are coming out that are also targeted. From the standpoint of looking at the systemics, I mean, I do, as an allergist, want to look at the allergic comorbidities, because
let's hold on that for a second, because we do have a list of them coming up on the next slide.
Sure.
So I will come back to this just so we don't lose this. So does regional, so I'll come back to the question that's on the slide is, does regional dermatitis influence your selection? If someone has a lot of facial dermatitis, you know, I guess the question is more projecting out. It's a year from now. Is it gonna change how we approach it if we start to get other new systemics beyond dupilumab? So for facial, hand, or genital, will that influence selection? So the hand dermatitis, I'll just say that, you know, delgacinib is being developed for hand dermatitis, particularly, as well as for atopic dermatitis. So the topical, you know, the question of how the topicals are going to kick in for that, and that's going to be enough to handle a certain percentage of patients. I think hand eczema, remember there's chronic hand eczema that's not atopic dermatitis related, though I think the younger you get, the more that hand dermatitis is atopic dermatitis associated, though sometimes with patients who had atopic dermatitis but may not be active other than their hands or hands and feet, and others where it's just part of the atopic dermatitis, and we hope to collect some data on that. We'll be discussing that at the PeDRA inflammatory group meeting in, I guess, in a few weeks. But facial dermatitis, does that move anyone at this point? Do you think it'll move us in a year, or what's people's sense?
I personally think it will, because these three areas I think of as quality of life dermatitis issues, just like I think of the patient who has generalized pruritus without much rash, but is truly miserable in their itch. And I think we'll have a lower threshold for using systemics because I think it really impacts quality of life, similarly to how we think of psoriasis treatment in children who have isolated psoriasis to the face or the genitalia.
Yeah, I think
I'd be more comfortable, I think, with biologics, I guess. And like you said, I think you can make the steps easier to these systemics relative to the traditional ones, you know, because they're less immunosuppressive. I am a little bit unsure yet about, like, would I jump to JAK inhibitors, since they are a little bit more broad, albeit we haven't seen huge safety issues, but I guess I do worry they work a little bit more broadly.
Why don't we roll on to the next slide, which has a different set of questions.
Yeah, this slide is in honor of Bob and my husband, who's a rheumatologist. So all those other inflammatory diseases that excite them so much, you know, what would we do with regards to comorbidities? So as we know, it's, you know, not uncommon for our atopic dermatitis patients to have all sorts of comorbidities, all of which are listed on the screen, including some that we don't necessarily always think about, including JIA, and also, you know, cardiovascular diseases and consequences thereof. And then, of course, the question of what do you do about the patients that have horrible conjunctivitis if it's chronic and refractory? I can say in anecdotal evidence that I've had the patients on dupilumab that I share with allergy who have, and GI who have EOE, have been the greatest improved with regards to their atopic dermatitis and quality of life in general, as well as their GI disease when taking dupilumab. And they've been very responsive to treatment. And I don't believe in my panel that I have a patient with bad EoE and atopic derm on dupilumab who has not responded. They tend to be my happiest dupilumab patients.
And Dawn, really, I'm very glad that you had this slide, because, you know, Larry and I have a joint multidisciplinary AD clinic, and really, I mean, one of the patients that we're bringing in for a testimonial video actually has EoE as well, and this young woman, I mean, responded beautifully to dupilumab. And that's kind of the way I sort of look at this comorbidities, because I think in the absence of really good biomarkers, we really kind of have to look at these comorbidities as almost a clinical biomarker in predicting sort of endotypes and response. So I would say that for the patients who have asthma and urticaria, EoE, and I mean, and even chronic sinusitis or polyposis. I mean, we have some other patients with nasal polyps as well, and these I would characterize them as having very high T2 signature, and they may do very well on the T2 biologics, as opposed to the ones with psoriasis, IBD, and JIA, which have more perhaps of a T1 signature and T17 signature. And some of those, I mean, with a T1 signature, perhaps using the JAK inhibitors, perhaps would probably be more effective in looking at some of those patients. So I think that, I mean, these comorbidities allow us to have a clinical biomarker to kind of decide on the course of systemic therapy.
Yeah. Does conjunctivitis keep people off of, so first of all, so right, it's the IL-4/13 dupilumab, you know, has conjunctivitis with it. The rates in kids are about the same as adults. I've definitely had patients who I was worried about putting them on it because of a history of significant conjunctivitis who did fine with it, with dupilumab. The IL-13s, you know, people were wondering if we could get around conjunctivitis. I don't think you get around them, though the rates in the studies so far have been lower. You know, Lebri hasn't weighed in yet, so they were only in phase 2s. Lebrikizumab, tralokinumab had some conjunctivitis, but generally lower rates than dupilumab. But we'll sort of have to play that out into practice and longer term studies to be certain about that. So.
I do have a comment to make on the conjunctivitis part. I think that, I mean, there's a lot of people who have various theories about why there's conjunctivitis. Some people believe that it has to do with the fact that some of these patients may have pretty significant eyelid dermatitis and people are rubbing, but I also think it has to do with the actual mechanism. I think one of the ways that IL-4 and 13 blockade works is that it dries things up in other places. I mean, in the upper airways and lower airways. And when you're talking about the airways, drying things up may be better, but when you're talking about the eyes, drying things up may not be so good. So, I mean, decreasing mucus secretion in the eyes may lead to some deleterious effects. And I think that through that mechanism is probably going to have some inherent degree of exacerbating conjunctivitis.
Yeah, and you know, there have been biopsy studies that were done that showed goblet cell depletion, and
right.
And I don't think that's expected from JAK inhibitors, nor has there been a signal of conjunctivitis beyond the baseline conjunctivitis rates that are in the population in
exactly.
to date, at least in my read. You want to go to the next slide and discuss?
Yes, absolutely. So next, please. This is a question that I think about because we have so much quality of life issues with patients with atopic dermatitis, and we know that they have increased issues with depression and anxiety and sometimes hyperactivity. Do we really know what these systemic medicines do with regards to mental health comorbidities, cause and effect? Is there an impact at all? I mean, I know that
what
when
do you
patients...
think? I mean, we know what the adult studies they did. You know, they did the HADS index, the hospital anxiety depression index, and you can see marked improvement. You know, clinical experience, I had incredibly depressed patients who like come in like incredibly happy, and they tell you, you know, I query that. They're like in a different world now with systemic therapies, you know, especially with dupilumab, which is so well tolerated. But if that's people's experience, we should say that. Yeah.
Yeah, I think of it as like my acne in my Accutane patients. When you look better and you feel better and your quality of life improves, your mental health also does the same. I'm just not sure at this point in the PEDS patients that we have any specific data. It's more clinical, you know, anecdotes. And I'm very glad to note that I have not had any patients get worse on systemic medicines when their skin disease improves.
No, it's a good point, because of course, you know, as we go to the research questions, the question of when to intervene. I think we're all wrestling with how are we changing our treatment, both our use of systemics in general, as well as traditional versus new. And then how is that going to be different when we get in agents that can be used differently, don't necessarily require longer term use. And the age of, you know, how more liberal should we be in using systemic therapy if we think we can alter the mental health course of individuals. Those are the sort of longitudinal studies that, you know, we have to discuss, you know, what's the best way to get that data? Is it going to be from non-specific registries in the disease state that we have going? Does it need to be drug-based registry, or there need to be just larger investments into longitudinal cohort studies?
I do want to make another comment about this, because one thing about mental health comorbidities is that, I mean, these patients, I mean, once they get horrifically depressed, the adherence is also going to drop. So if we're asking somebody horrifically depressed to put on, I mean, a topical agent twice a day, making sure they're taking bleach bath twice a week and moisturizing minimum twice a day, I just don't know if really we can, I mean, how you can motivate someone who's horrifically depressed to be doing all those things with minimal results. And I think that that's one of the other considerations that we do need to take account of when we think about we may need to have a lower threshold to start targeted therapies for these people, because they may not be adherent enough to really comply with all the things we need them to do from a topical basis.
Yeah, I think also so yes, one of the comorbidities we recognize, right, is the family impact of the disease. You know, so now we're starting to do the DFI, the Dermatitis Family Index, in some of the studies, and that's another thing that may rationalize us getting more aggressive early, because, you know, the first few years of life, there's a lot of impact with individuals living there. The family lives around the disease state. So I guess that's
I'm not aware of any studies doing like the Columbia Suicide, you know, scale and detecting depression as they do for psoriasis drugs, right? Are you aware of that, Larry? I don't think they studied that to that extent, you know, which would actually be, in hindsight, good, less for risk, but they have the data to show improvement.
Why don't we move to the next slide? But I am going to take a little bit of a detour, because the next slide just sort of talks about mixing and matching. Oh no, back one. I'm sorry. There should be which treatment to choose. Okay, there we go. Let's, yeah, this one, yeah. And the timing of drug. But before we get to that, there's several questions that came in with us on topicals that I think are worth bringing to the group. So one is the question about systemic absorption with topical JAKs.
So from the studies thus far, like the ones you mentioned, they found very low levels of drug in blood. So they weren't felt to be affecting it. I will say lab-wise, they didn't see any major changes in cell counts. The data that I haven't seen yet for the younger kids, which I know FDA was looking at, is that they were looking at bone markers, because there was, you know, based on animal studies, a question about whether there might be increased bone turnover. So that I have to say I haven't seen a lot of data yet to see, but there's been no data that has halted the trials, I guess, they've continued on enough.
But you should, from a pediatric standpoint, you should recognize that the trials for topical Rux limited BSA to 20%, because I think they were concerned, and we haven't seen the full PK data set from that. So there's been no lab abnormalities or clinical abnormalities, but that is an issue of whether we have to be protective in body surface area because they're worried about the, what the effects of absorption can be. There's also the question of the label, right? Because systemic JAKs have labels associated with them for the other indications, and whether a topical would do that or not is an issue. The other question, Winnis, is about have they looked at any analysis on facial disease, either in terms of tolerance or other, or efficacy or adverse events in these drugs or not?
They did facial disease, I think, for Ruxolitinib, and I think it mirrored what they found for overall in terms of efficacy. I'm not sure that they parsed out, though, AEs by body surface area, body location. So
remember that what happened with crisaborole is that it was so long ago, believe it or not, even it wasn't that long, but in the history of atopic dermatitis, that the harmonization of measures of eczema group hadn't weighed in time about what the core outcomes would be, so that when they did the crisaborole studies, they didn't do an EASI score. They didn't do a SCORAD. Their sense was all they needed was an IGA, and that's what they did. And they did a localized, little local tolerance and local signs and symptoms, but they didn't do the formal EASI scores. Once you get the formal EASI scores, then it's easy because you can look at the facial subgroup, at least in terms of efficacy, because that's one of the, head and neck gets specifically tested. And they hadn't done that previously, though. In the infant study, they did include EASI scores, just the difference in the timing of the study. And Bob Silverman is saying, JAKs don't seem to be too specific. Don't they affect keratinocytes, endothelial cells, Langerhans cells, and fibroblasts? And I guess, yeah, but of course, JAKs are like, they're a panoply of different JAKs and combination of the different JAK receptors that mediate different subgroups of both cells and the cytokines. So, which brings us, I think, to the question of stop-start biologics versus JAKs. So I have to say, my psychology fits with that question. I said last week that when I start dupilumab, I sort of tell patients we'll do it for a year and then we'll talk about the second year. And then it's not an expectation that we're just going to do it for a few months. And that's partially because of my concern about stopping and starting an anti-drug antibodies, even though the data on anti-drug antibodies with dupilumab is pretty good compared to most of the psoriasis biologics. And the JAKs won't have that limitation. They're oral and they're small molecules. But Winnis, do you have any input on oral JAKs in your sense of how you might use them differently, or is it just too early to know?
It's a little early, but I mean, just based on seeing for other inflammatory diseases and from alopecia areata, and I mean, I do think a little bit. Obviously, we're in a pandemic too. I do think a little bit about keeping people on JAKs long term. I mean, I think I'd probably be comfortable, get them better over 9 to 12 months, but I might move them faster back to try to get to topicals, hopefully more efficient topicals, that sooner than I would with a biologic, which I'm more comfortable doing up to a few years, if needed.
So we showed the oral data last week, right? And so abrocitinib, so upadacitinib, we just don't have the official data yet, but we just know it's really strong. Abrocitinib, we've seen the data. Remember, they have a separate team study, so that'll influence the PeDRA world when that comes out as well. So it's pretty quick. And, in that population study that drove them to higher levels of higher, improved EASI scores. Of course, it's not head to head, but, and it's quick and very quick for pruritus. So it's going to be really interesting to see how we make our decisions depending upon really how we educate the patients and how they come to their choice. I think the comorbidities will matter, what patients' expectations are in terms of injections versus orals.
So Larry, I do have a question. So I mean, given the rapidity of how fast the JAKs can work and without the concern of immunogenicity, I mean, maybe, this is a discussion off label from what it's going to be approved for, but I mean, short-term use, to get people over a hump, a month or two, to get people over a hump, like especially since, there's going to be variability in the course of AD throughout the year in some patients.
Yeah, but it'll be really interesting to see then if you do that, or are you going to be able to do, you're going to be able to do free-form tapering dose and then moving people into aggressive topicals, because at least with some of the medications, like the UPA data, looks like there's a lot of quick rebound.
Mm-hmm.
So more like cyclosporin. And if that's the case, we just need to make sure we manage that part of the, that part of the treatment. But I do think, yeah, that'll be the, and then we have down balancing safety versus rapidity, because long-term JAKs, they'll have a label of malignancy and other stuff, whether it's significant enough. But, remember, the dermatology population generally comes at this without a lot of other systemic meds as compared to the rheumatoid arthritis population that have been through a variety of cytostatics and more aggressive immunosuppressives. So some of the data sets are more worrisome in terms of malignancy and stuff. We've had the same thing with psoriasis, right? There's very little, bad stuff that's come out of the psoriasis extended experience, but they've generally not been on the history of meds that the RA patients have. And
then there's the concept of perhaps combinations. I mean, if Dupi is able to get you, or the biologic is able to get you 40%, 50% well, I mean, can we potentially add on a JAK to that? And I mean, yeah. And the impact on that, I mean, may be interesting too.
And then nemolizumab was mentioned. Dawn said it was the favorite, but I think she thinks it's the favorite because of the Nemo name, not because
it's a cute pediatric name.
And how that will fit in, and that which is I think something that we'll see as they do their PED studies. Dawn, you think we're ready to move on to sort of
absolutely
questions? Great.
So really deep thoughts by Dawn Davis of what I think is next in the pipeline and questions that I think of when I think of these concerns, and I'd be happy to hear others next. So with regards to pediatric AD research and just PEDS research in general, thanks to PeDRA and others, we are definitely accelerating the amount of pediatric dermatology research and pediatric research in general. And I think that's wonderful. We still have a very long way to go with regards to the diseases we care for, and we still have to do a lot of catching up relative to our adult colleagues. Of course, with this comes physician effort and participation, because this takes time and infrastructure, which a lot of practices don't have, the resources that is required to really be successful in this realm. So there's some infrastructure things we need in addition to enthusiasm and participation. Next. But with regards to topics, do we use this for just a single disease, or do we do combined diseases? So we need studies on that. And then how do we expand it to our other allergic armamentariums that Bob is an expert in, like hives, polyposis patients, EOE patients. So we need a lot of combo studies. And then what do we do about those patients that have isolated atopic dermatitis? They're a special type of cohort in my mind. If you have only isolated hand-foot disease, or for example, face-only or genital-only disease. And then I query, even though it is a different mechanism, is there a role for any of these drugs in food allergy, either prevention or prophylaxis, or for comorbidities with our food allergy patients? So Bob, as our resident allergist, I don't know if you have any thoughts.
I do have a few comments on that.
Yes, please.
I'm really glad that you mentioned the last part here, because dupilumab is currently in phase 2 for food allergy. Mm-hmm. And so people are looking into this. I think that there's also Karen Nadeau's group in Stanford is also looking at using omalizumab for multi-food desensitizations. But I think, directly from a treatment of food allergy standpoint, how that impacts AD, I think that's also really interesting, because the common adage is that once the AD gets better, then the sensitization level should fall. And we're actually collecting this data in our multidisciplinary clinic with Larry to see whether that can hold true, trying to correlate the EASI score decreases with the sensitization changes. But I think that, interestingly, I'm also asking Aimmune, because they're the ones with the peanut desensitization, the only FDA-approved peanuts desensitization drug. And they've collected AD data, they have not examined it. So one of the things I've asked them to do is actually to go back and look at the data to see whether the AD, any of the markers of quantifications or metrics they use actually changed over time throughout the course of their trial, to see whether in an inadvertent effect, the AD for the patients who had it as a comorbidity actually also improved with the desensitization to peanuts. So that'll be really interesting to see. They have not looked at cut the data like that yet, and they said that they are willing to look at that. So I mean that we may have some answer to this question sooner rather than later.
And then Bob, can you clarify? Oh,
sorry.
Linus,
Question in whether for the food allergy studies, are they testing clinical improvement in food allergy skin testing, or what are they?
So they're actually looking at challenge studies. They're actually, yeah, so these are high risk studies. Basically, they're taking people who definitely have food allergies to these foods and then doing challenges, graded oral challenges. So, I mean, if there's any, potential, if we look at the environmental allergen side, I mean, if there are various studies with adult patients with dust mite-driven AD with SCORAD greater than 45, randomized control studies have shown that in those patients, allergen desensitization led to clinical improvement in AD from a SCORAD standpoint. I mean, if we think that if we take the corollary, I mean, perhaps we may be able to see that same type of result in kids in food desensitization. It's too early to tell right now, but I mean, I think it is important to take a look at that data.
Yeah, that was my question for you, Bob. Is the study looking at desensitization and the safety thereof, or exposure prophylaxis to prevent anaphylaxis, or both?
So it's really going to be prevention of anaphylaxis. They're not going to, I mean, it's not out to let people go and eat a peanut butter jelly sandwich. I mean, it's really if they have accidental exposure to prevent the development of anaphylaxis, which is one of the main reasons why it's highly criticized, and a lot of people in my field are very skeptical about the adoption of it. But I think that it's a step towards the right direction, and I think it's and I'm curious to see what the impact is on other comorbidities such as AD.
Okay. And then next,
so one question, though, which we haven't wrestled with the methotrexate question, so we still get, I write for dupilumab for a patient, I get they haven't tried methotrexate, and I actually fight that. I just go right at it and try to get on the phone with the medical director. There was that paper came out last year on psoriasis, the Bronkers paper, where they put together a group of patients treated with methotrexate and psoriasis and compared their outcomes to biologics. It was like any biologic that they used, and showed that the improvement level was much better with the biologics, and those were probably mostly first generation, TNFs. So I don't know if we're going to be able to get comparative data like that. In the U.S. is usually traditionally miserable at doing prospective comparison studies because they don't require them for drugs, but it would be useful for us to do that. But does anyone just say, yeah, I'll go through methotrexate automatically, or do they fight it right now?
Well, I don't know. You may be better at fighting it than I'm fighting it.
I try to fight it. I don't often succeed.
I do have some that I have to put on something first before it, but you may be better at fighting them than I am.
I think in our region we've been lucky. We haven't had to do as much fighting.
Okay.
So hopefully.
It's hard in Southern California. So I mean, Bob and I are fortunate because if they come to the multidisciplinary atopic derm program, it's like 2-hour visits where they're getting like all these PROs and easy scores, and it's like, we list 9 people there who said that they should get the medicine, so it's a little easier if we have to argue with the.
I mean, we have clinical pharmacists, and you have Larry and I sitting there for a whole morning seeing 5 people. So I mean,
not our usual one. Okay, so that's a good question. And the other question, of course, is how do we contribute to the data on early treatment and how it's going to change the course? That's one. And then I think later on you have the question of the phenotype. So we have a PeDRA. On this slide, we say hand eczema. We'll discuss that at the PeDRA inflammatory skin disease group because we have both a survey and a potential prospective study on categorizing hand eczema. that we want to do. When it comes to the phenotyping studies in place, but the question of translating phenotyping to, can we figure out who the super responders are for the different medicines? And
so on the next slide, please. More deep thoughts. You know, where else can we use these medicines? I've found some patients. I remember the first patient I used dupilumab on with guidance from Tony Mancini was a patient with really bad generalized pruritus and prurigo nodularis who did quite well on dupilumab. And now I'm much more likely to pull the trigger now on my atopics who itch more than they rash. And most of them get a lot of benefit from that. Is there crossover into the other Th1 diseases like we had discussed earlier? What about other Th2 diseases like AA? What about immunobullous disease? There's been some thoughts, of course, in the literature in adults. You know, is this helpful for bullous pemphigoid? There's been a report of a bullous pemphigoid patient taking dupilumab with success, but then developing CTCL. There's also been reports of, well, maybe this could help CTCL patients. So perhaps it's patient dependent. And then next, please. Then other concerns or considerations would be phenotype variation, as Larry had mentioned earlier. I think there's definitely relevance with quality of life studies, particularly with mental health, but also with sleep hygiene, because I feel like sleep hygiene kind of rules the world, especially in a pandemic where we're all virtual. And then we don't know much about length of use. We don't know much about antibody development. And do we stop cold turkey versus wean? And if we restart, at what point do you have to double the dose of Dupi again or not? Is there antibody formation in Dupi? Not as much as with other drugs that we know of at this point. And then topical formulations, please. Everyone always asks about topical JAK inhibitors, particularly my AA patients, but I was very thankful to learn from Winnis today about topical JAK inhibitors, but what other, you know, will biologics be topical? Who knows? So.
You know, it's interesting because, I mean, one of the ways that, one of the food allergen desensitization studies is using an epicutaneous patch, and it's allowing them to delivery of large proteins through the skin. So if you can, I mean, and what's preventing the delivery of biologics through the skin is because it's the transport of these large proteins across the skin. But I mean, if there's other technologies that allow that kind of transport across the skin, I mean, you can potentially have topical formulations of biologics, which will be really exciting. But I mean, I think the technology is probably not currently there yet.
Yeah, I think we're going to have different drug delivery methodologies other than just it's a cream and ointment and you put it on. And I think that that may drive, especially alopecia areata, it's getting, the topicals have had a problem getting into the follicles and rid of the follicles and not just into the bloodstream. So that may be something potential.
I do want to make one comment about the sleep hygiene, because if we want to make sure that people aren't falling over and sleeping, I mean, I know that a lot of people like to use hydroxyzine a lot, but I mean, and in the right times, I mean, at nighttime, I mean, it's fine, but to use hydroxyzine round the clock, I mean, it do a real disservice from a sleep hygiene perspective. So we've really, in allergy, tried to move over to the second generation antihistamines. I mean, we prefer using things like cetirizine far more because we're not really making people extremely drowsy or having to dose them frequently after that. So, and there's an increasing amount of data, especially in the elderly population, that the first generation antihistamines may not necessarily be great from a cognitive standpoint. So there's issues from the aging brain. There may be also issues from a developing brain. So we're trying to move away from using more of the first generation antihistamines.
Okay, well, we're about an hour and 15 into it, and I'm thinking of sleep hygiene and the people. You know, there's plenty to discuss. I think every few months we're going to be getting more data out on some of the new drugs, and we'll be living through these issues of how we use drugs, when we use them, which are the patients, what are the factors that influence that. We do have 2 more events coming out of this series, which will be the plans to do sort of interview podcasts, which we'll send out broadly, and then we'll have sort of what we're calling town halls, but basically it's going to be time for us to talk through some of the issues, again, with Liberal getting input from the attendees as well as the panelists, as we go through sort of the practical aspects of our evolution in management of atopic dermatitis. So I thank the panel. Great job today. Great talks, Dawn and Winnis. Thank Mike Siegel, Jen Dawson, and the rest of the PeDRA group for getting everything together, and smooth technical work as well, and for helping us to put together the series. I thank the attendees. We again have people from Venezuela, Australia. It's fun to see an international group supporting both our activities in atopic derm and PeDRA. Thank you guys. Have a great night.